And I will leave the mic now for Professor Ahmed Al-Yash.
Now, with the last flashback, Professor Mohamed Zahran, Ain Shams University. I think Professor Mohamed, intervention flashback.
Yes. So, congratulations and thank you, Professor Said Farag and Professor Ashraf Rida and the whole board. What I like about the IAVA sessions is always like, it feels like family with friendly atmosphere and high-grade science. It was not planned that Professor Bindari will present clinical scenarios, Professor Farid imaging scenarios, and then I'm presenting intervention scenarios, but I learned a lot actually from both of them. I got 2 out of 3 Bindaris, and I got Ahmed Farid, so it looks like I'm still having some skills apart from the cath lab. So definitely you know that's going to be an intervention case. This is a 58-year-old gentleman. He's smoker, hypertensive, with a positive family history for ischemic heart disease. And this gentleman presented by an acute coronary syndrome 6 months previously in another hospital in another city outside Cairo, for which he performed a coronary angiography which showed a totally occluded proximal right coronary artery with retrograde filling from the left system and some antegrade filling as well. So definitely the patient was indicated for a trial of PCI procedure.
Outside Cairo مش في الزقازيق ها؟
Not the Aziz, no, but it was elsewhere in the Delta.
Outside Cairo دي يعني مقلقة شوية.
دلتا يعني عنصرية شوية، أنت عارف إحنا عنصريين في القاهرة، ومن الدلتا عايز المحافظة المحددة نخلص وأقول لسيادتك. It was a little bit difficult to cannulate the left system, so it was cannulated by an amplatz. You can see that the left coronary artery LAD shows some atherosclerosis, osteal disease, diagonal branch, huge, massive septal collaterals for the right coronary. It looks like a big right, which was a bit difficult to engage also. And then there were trials of PCI with a PT2MS, a pilot 50, a pilot 150 with a balloon of 1 and 1.5. Those trials were ended when the patient developed severe chest pain and hypotension with a huge dissection of the right coronary artery. The patient was hospitalized for 3 days in the hospital. There was some staining in the wall of the right coronary artery. He performed an echocardiography pre-discharge. There was no pericardial effusion, so perforation was excluded at that time, and he was referred for another session later on, during which he was kept on full anti-ischemic medications. So after 2 months, I saw the patient. After the first procedure, he had chest pain on exertion. His heart rate was fully controlled on beta blockers. Blood pressure was adjusted. I performed an echo. His ejection fraction was normal with a segmental wall motion in the form of hypokinesia of the infraposterior wall and mild mitral regurgitation.
Zahran, I'd like to stop you here.
Okay.
What do you think that that 2 months after the first attempt was a good time to do your second attempt, or you have to have much more time, or it is a little bit delayed? What do you think? The optimum time for the second attempt?
What we read in the literature is after 6 weeks plus. So after 6 weeks plus, the literature says that usually the dissections that happen in the first procedure of the CTO are healed. This is what we read, Professor Said. What we see is that it's different than what's written in the literature, because the first attempt of the CTO PCI here is different than the first attempt of the CTO PCI there. We usually go with 1, 2, 3 wires, 1, 2, 3 balloons. We inflate the balloons. We go with stuff that makes the artery actually split. So what I have seen, this is a personal experience. It does not written anywhere, but what we see, because we do lots of these procedures, as you know. I usually never saw a patient after 2 months, 3 months, even 6 months with a healed dissection.
Yes, because the different first attempt then mentioned that
if I'm lucky enough, I can see a track and a false track. This is if I'm lucky enough. But usually, after 2 months, we will see what we are going to see in the next image now. So the plan, of course, was the patient came consenting for a trial of revascularizations. The equipments were prepared and the plan was set as follows. Dual injections mandatory, guiding with the Judkins and the amplets available. The families for the antegrade wire escalation and the retrograde, the fielders, the Gaia and the Conquest, and the microcatheters, Corsair and Caravel. And this is the second attempt done by myself. Dual injections from the guiding XB for the left system and the guiding Judkins right for the right system. And as you can see here, the right coronary is totally occluded now, and you can see multiple planes of dissection down nearly just before the bifurcation to the PDA and posterolateral. There is retrograde filling, and there is, of course, some antegrade filling, as you can see. So if you have an ostial or paraostial CTO, then you will go retrograde for sure as a start. If you have something like this, you can go for a short antegrade trial because I have only 2 minutes. So this is a BMW wire, and this is a Caravel microcatheter. And the Caravel was parked at the proximal cap in the proximal right coronary. As you can see, the BMW was taken away, and then a fielder XTA was advanced across this microcatheter, as you can see here. The turning point.
Zahran, we would like also to stop to make some stations
Yes.
here for selection of wire. For the second attempt, do you prefer a polymer jacketed wire or non-polymer jacketed wire? I think this is worthy to mention here in such a case.
I have an antegrade filling. I can visualize a right coronary artery. I'm preparing myself with a very gentle tactile sensation. I will start with a very soft polymer jacketed wire. The fielder family will help here. The turning point will be putting this with the minimum loss of length from the dissection, because you will go through the dissection and you will steer yourself to the true lumen. The right coronary gives you some confidence because the branches are down. Once you finish the caudal, the RV branch, you get 30 or 40 millimeters of a free right coronary, and you have a bifurcation down there. So you are a bit confident even if you go through the dissection down there. Here the dissection is very proximal, so you need to steer your wire to the true lumen. The fielder will offer you this in a little bit of safety manner so long as you don't push a knuckle. If you push a knuckle, خلاص, this is force, you're dissecting. If you don't push, لو الواير ما عملش منك knuckle زي ما انا تاني صباعي كده, you are still on full control of your wire. If you have a good tactile sensation, by experience, you can steer it back to the true lumen, as you will see here exactly. So this is the fielder entering the microcatheter, and the fielder drops to the dissection plane. This is the most important point. I'm putting the 2 screens here beside you. This one and this one. So this is in the false. شايفين الكوع اللي اتعمل ده ملي واحد بالظبط وري انتر تاني في الترو. I will make it play. This is the false. The wire is not in the true lumen, and here الواير قلب تحت بالظبط ملي ودخل تاني في true lumen, confirmed by the injection. Anti-gradely طبعا احنا شغالين fluorosafe retrograde injection to confirm our exact position. This is the most important point here. خلاص, you will drive your wire distally. You will follow it up with the microcatheter. For educational purposes, I am showing you the trapping technique. This is the microcatheter going down there. Distally, النقطة اللي داخلة لجوه دي المايكروكاثيتر. The wire is taking out المايكروكاثيتر جوه. الواير طوله 190 سم، المايكروكاثيتر 150 سم. هتشدهم بره لمسافة 40 سم، هتلاقي الواير والمايكروكاثيتر جم على ايدك. مش هتعرف تشد، هتشد المايكروكاثيتر الواير هيطلع معاك. بتعمل حاجة اسمها بالون ترابينج تكنيك. You push
For
the
educational
wire.
purpose, also the size of the balloon.
Yes, it's a 6 French guiding catheter. I use a 2 millimeter balloon. In the 7 French, we use a 2.5 or 3 millimeter balloon. زقينا البي ام دبليو جوه المايكرو كاثيتر. خلاص كده ورك هورس واير عادي، عايزين نشد المايكرو كاتيتر لبره، بنشدها لغايه ما هتيجي بعد الواي كونكتور الاثنين هيجوا على بعض. اول ما يجوا على بعض البالونه داخله، النقطه بتاع المايكرو كاتيتر في الشافت اهي، البالونه داخله جوه، البالونه مش داخله على واير، داخله ساده كده على الواي كونكتور. انفليتنج ذا بالون، يبقى انت حاطط صباعك على الواير جوه المايكرو كاتيتر، هتشد المايكرو كاتيتر، الواير في مكانه، هتطلع البالونه دي وتحطها على الواير وتخش تعمل بي تي سي اي بروسيدور عادي جدا كانك شغال سمبل بي سي اي بروسيدور. This is the pre-dilatation. هنا هيبان بقى الدايسكشن بلينز كانت واصله لغايه فين. After the
I saw you do milking with the balloon.
Yes, I do that.
Ah.
I do that because I want the true lumen to expand a little bit and lay down the
That's why I'm asking.
to
Reconstruct the
channel of the right corner.
Yes.
Here you will see النقط البيضاء اللي لغايه تحت دي كلها بقى الدايسكشنز، اللي هي حتت اللي الفيسل فيها lost continuity، دي الحتت اللي حاصل فيها دايسكشنز. كان في دايسكشن تحت مش مبين البي دي اي برانش، عملنا مجرد ما عملنا دايلاتيشن بس ظهرنا الترو اليومن، هتلاقي البي دي اي ظهر معاك كويس قوي في الانجكشن دي، ظهر تحت اهو خلاص. you will not need to stent this area. انا محتاج دقيقه واحده كمان. I put 3 stents. The distal one was 3. I started by the middle. ليه started by the middle? Because I don't want to stent very long. I want to stent only what's necessary. فأنا I stented as distal to the middle as I like. وبعدين I will see what's going to happen. This is dilatation, and then I put another stent rising to the ostium with flaring. بعد كده لقيت إنه dissection كان واصل لجوه خالص في الحتة اللي بعد الستنت مباشرة. But I do not need to put a very long one to the bifurcation. I'm only sealing this one by a short stent. اللي جوه كان 3، اللي بره 3.5، اللي فوق خالص 4. which shows you how much big this vessel was. وبعد كده خلاص روتين بوست دايلاتيشن بنون كومبلاينت بالونز لغايه الاوستيوم من فوق كده right coronary, as you can see how huge it is and how distal it's reaching. ما نخافش من المنظر الديستال للستنس، الفيسل ده بيكبر بعد كده وبيحصل له ريموديلنج، عامل زي خرطوم الجنينه المتطبق اللي بقاله سنين ما جريش فيه ميه، بتوصله بالحنفيه بيملى ميه بس ستيل متطبق، طول ما الحنفيه شغاله الخرطوم بيكبر والفيسل بياخد النورمال سايز. انا بس محتاج اقول التيك هوم مسجز in less than 30 seconds.
Dr. Mohamed, I want to say one thing. It's a very nice case, and I think one of the most important lessons here that you minimize or the length of the dissection is not too much. Otherwise, you will get just a tube without blushing,
Yes,
without
I don't want to do this.
any antigrade flow.
I don't want to do this.
Myocardium will not benefit.
I'm prepared
Yeah.
for retrograde
Yes.
here because I don't want to dissect this right cornel. And زي ما انت شايف البرانشز طالعه من اول الكونال، كل 10 مللي في برانش طالع.
There is some
I don't want
tertiary
to lose
branches
any
there
one of
also.
those branches. Points to remember.
Not to agree on dissections, but dissecting the proximal and mid-right coronary, the amount of myocardium given by the proximal and mid-right coronary is small.
Small.
So just small
Yes.
point. Thank you so much.
So even if it looks simple, if you have anti-grade filling in the first attempts, it might not be simple. Respect what the previous operators did and learn from their failures to plan for your success. It's always wise to know when to stop. He stopped the first time when the patient developed chest pain, hypotension, and massive dissection. You don't need to continue beyond this step. Do no harm is the rule of thumb of any intervention or surgical procedure. Prepare your toolbox and know your enemy so you can plan for success and know how to use this equipment. Thank you.
Thanks.